Welcome to our video on cardiac chest pain, acute coronary syndrome. Acute coronary syndrome is an umbrella term encompassing the following clinical disorders: unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. Unstable angina is from either atherosclerosis rupture or coronary spasm, which results in partial or intermittent occlusion with no myocardial damage and can lead to myocardial infarction, which is either NSTEMI or STEMI. NSTEMI is partial or intermittent occlusion with myocardial damage and can be seen on an ECG with no ST segment elevation. STEMI is complete occlusion with irreversible myocardial damage and can be seen with an ST segment elevation, which is evident on an ECG. As you can see in the concept map, STEMI and NSTEMI both have similar predisposing risk factors, as well as symptoms of crushing chest pain, shortness of breath, and gastrointestinal upset. However, NSTEMI does often not show some of the symptoms related to activation of the sympathetic nervous system, such as increased adrenaline and gastrointestinal issues. STEMI and NSTEMI both have similar clinical management goals as well as medication management. However, with STEMI being more intense related to the full blockage of arteries, it is often needed with more intensive interventions such as surgery. The heart is composed of cells called cardiomyocytes. These cells have a high demand for oxygen, which is supplied by our coronary arteries, which are branched from the aorta into the left and right coronary arteries. However, in acute coronary syndrome, formation of atherosclerosis in the walls of coronary arteries or coronary spasm can limit the oxygen supply to these cells. Atherosclerosis starts with high-level low-density lipoprotein, LDL, floating in the blood. Theory suggests that such high levels of LDL can be deposited under the endothelial cell layers of coronary arteries and can be oxidized, causing inflammatory reactions which attract white blood cells. Macrophages in the tunica media, which is under the endothelial cell layer, then uptake lipid and become foam cells. Foam cells become the necrotic core of the atherosclerosis, causing blockage of blood vessels. Accumulation of fat, cholesterol, and calcium also contributes to formation of plaque. Rupture of the plaque leads to formation of blood clots and can further limit the oxygen supply. Coronary spasm is a sudden constriction of coronary arteries. Narrowing and obstruction of blood flow in coronary arteries will disturb efficient oxygen supply to cardiac muscle cells. It is caused by an imbalance between vasoconstrictor, prostaglandin, and vasodilator, nitric oxide. Other mechanisms have not been discovered yet. Some of the predisposing factors for coronary spasm include alcohol, emotional stress, exposure to cold weather, and vasoconstricting drugs. There are three types of acute coronary syndrome, which is unstable angina, STEMI, and NSTEMI. When there is a partial blockage of the coronary artery and temporary depriving oxygen supply to cardiac cells, it is called NSTEMI, which meaning there is no ST segment elevation on an ECG. When there is a rupture of coronary arteries and an irreversible damage, for example necrosis of cardiac cells, it is called STEMI, and there is an ST segment elevation evident on an ECG. ST elevation indicates the electrical conduction of the heart is malfunctioning, where ventricular depolarization and repolarization happen abnormally. Unstable angina is usually due to unstable and fragile atherosclerosis and has an unpredictable course of pain. Stable angina has plaques or atherosclerosis with a fibril capsule. However, unstable angina does not have a fibrous capsule covering the plaques and can easily burst. Blood clots formed from ruptured plaques can cause partial or total blockage of coronary arteries at any time. As you can see on the picture in the slide, the plaque buildup on the vessel walls is constricting blood flow and can totally constrict blood within the coronary arteries. This can lead to myocardial infarction and cardiac cell damage. There are modifiable and non-modifiable risk factors for acute coronary syndrome. Smoking has the biggest impact on the cause of ACS. Nicotine is a vasoconstrictor and also increases the viscosity of blood, therefore increasing the chances of unwanted blood clots and plaque formation in the blood vessels, leading to atherosclerosis. Also, nicotine and increased oxidative stress from smoking induces vascular endothelial dysfunction, as well as decreased generation and bioavailability of nitric oxide, constricting vessels. Hypertension increases risk of plaque rupture, which then causes atherogenesis. Low density lipoprotein, as mentioned before, is one of the key elements in the formation of foam cells, which is the necrotic core of atherosclerosis. Diabetes, with associated high blood glucose levels, increases expression of vasoconstricting agents and enzymes responsible for LDL oxygenation and subsequent atherogenesis, which can be a triggering factor of ACS. Other risk factors of ACS are age and family history. People who are older than 65 years old showed higher prevalence of ACS than the younger age groups. Having family history was proven to be a risk factor for ACS in many studies. The most common signs and symptoms of ACS are crushing pain in the chest and radiation of pain in arms, jaw, neck, back, or stomach. A heartburn-like feeling is common in women experiencing cardiac chest pain. Lack of oxygen supply to the myocardium causes crushing pain in the chest. There are 4 different types of angina. The angina, which refers to the pain following ACS, can be stable, unstable, variant, or silent. Stable angina is only manifested when there is an increased demand of oxygen, such as during exercise or when the person is emotionally stressed. Unstable angina has a sudden onset of pain, and the course of pain is not predictable. It is common in patients with atherosclerotic plaques. The pain can be present even at rest. Variant angina, also called vasospastic angina, is usually due to coronary spasm. It is caused by the imbalance between vasoconstrictor, prostaglandin, and vasodilator, nitric oxide. To diagnose whether the myocardial infarction is STEMI or NSTEMI, an ECG is the most effective diagnostic method. An electrocardiogram measures the electrical impulse and activity of myocardium. A 12-lead ECG has electrodes attached to the areas on the upper and mid-chest and all 4 limbs to detect the electrical currents generated by the heart. Electrical activity is segmented into P, Q, R, S, T waves and recorded on a graph. A normal, healthy individual will show regularly spaced and healthy electrical conduction as seen in the image. However, patients with STEMI will show elevated ST segments on the graph, or ST depression in NSTEMI, both seen in the image presented here. A coronary angiogram uses X-ray images to detect any blockage or narrowing of coronary arteries. A special X-ray detectable dye is inserted into the arteries through a cardiac catheter. Through a series of imaging, medical practitioners can detect abnormalities within coronary arteries. When there is irreversible damage to cardiac cells, it releases cardiac cell-specific proteins called troponin and creatine kinase MB. Presence of these components in the circulatory system through serum markers in blood testing is an indication of necrotic myocardium damage and is used to diagnose STEMI or NSTEMI. Unstable angina and stable angina do not show presence of these components in the blood. An echocardiogram utilizes sound waves to produce a live animation of the heart to check whether the heart is functioning normally. A CT scan produces cross-sectional images of the heart and allows detection of abnormalities in coronary arteries. It can detect plaque location and degree of stenosis. All methods combined can be an effective way of diagnosing acute coronary syndrome and myocardial infarction. Regarding acute coronary syndrome, the main goal of the healthcare team within a hospital setting is to reduce and eliminate the pain the patient is experiencing, increase circulation of blood flow, and restoring the heart's function back to its original condition in the most effective and timely manner way as possible. Once stable, educating patients about their diagnosis and ways to manage their diagnosis is highly necessary to ensure optimal health outcomes and follow-up in their care. This also involves the person in their care and is person-centered. Clinical management includes pain management by providing oxygen if saturations are below 95% or in respiratory distress, and pain relieving medications. Oxygen has been evidenced to be also assisting in pain relief. Creating a medication plan specific to the person can prevent further cardiac complications forming and further deterioration in cardiac function. Another clinical management technique is creating a personalized care plan to address risk factors involved in their diagnosis. For example, medications to manage their risk factors, improving diet and exercise regimes, lifestyle interventions for factors such as smoking, or environmental interventions such as assistance with accessibility to services. Reperfusion therapy to restore blood circulation to blocked arteries is a key strategy in decreasing mortality and further cell damage. This can include either medications or surgery. When treating acute coronary syndrome, many medications are administered to patients, often together. Medications that help with pain, medications that help to manage risk factors involved in a patient's diagnosis, and medications to restore heart function are most commonly used. Pain management options include oxygen and other conventional medications. Oxygen helps reduce any prevalent pain by traveling through tissues in the blood and to promote pain relief and healing, whilst conventional pain medications are used to reduce and/or eliminate any pain by blocking pain receptors traveling along the nerves to the brain. A common conventional medication used to treat pain in acute coronary syndrome is morphine. For acute coronary syndrome, morphine is usually administered through IV at doses of 2 to 4 milligrams every 15 minutes as necessary until pain decreases. Medications that help to restore heart function may also be prescribed in the aim to recover the patient from issues they are experiencing. Some medications that can help to restore heart function include nitroglycerin, which increases nitric oxide to widen blood vessels, thus improving blood flow. Thrombolytics help to dissolve dangerous blood clots within blood vessels, which improves blood flow and helps prevent further unwanted blood clots. Beta blockers to help relax the heart and therefore slowing down the heart rate and lowering blood pressure are often used. They decrease the oxygen demand on your heart, easing the stress, and can minimize cardiac cell damage. Medication prescriptions to manage risk factors involved in the diagnosis of acute coronary syndrome may also be done. An example of this would be patients who experience hypertension, prescribed with diuretics. Diuretics help to increase urine output through the kidney to get rid of salt within the body to maintain safe blood pressure. Statins are also often given to reduce cholesterol in the body. They reduce the level of plaque-forming LDLs in your bloodstream, lowering the risk of repeat acute coronary syndrome and myocardial infarction by up to 25%. Before administering any medications to patients, it is important to educate them about the side effects and precipitating factors of their prescribed medication. In doing so, it allows for medications specific to the patient to be administered, whilst allowing them to manage their diagnosis independently. It is also important to educate the patient on the importance of lifestyle changes alongside medication management, as exercise, diet, and smoking are extremely influential on heart function, health outcomes, and lifespan. Complications that arise from acute coronary syndrome occur when the heart is deprived from oxygen-rich blood. Depending on how badly the heart is damaged, determines the severity of a complication occurring. Common complications that occur from acute coronary syndrome include chronic heart failure, cardiac arrhythmia, pericarditis, myocardial rupture, thrombosis, and ventricular aneurysm. Heart failure presents due to the stress that ventricles put on the heart. Patients that have large infarctions, diabetes, hypertension, diastolic dysfunction, and mechanical complications are more likely to experience heart failure from ACS. This can be managed with loop diuretics, vasodilators, and ACE inhibitors. Cardiac arrhythmia is the irregular beat of the heart caused by poor blood flow to the chambers of the heart and disorganized electrical signals. It occurs in more than 90% of people who experience myocardial infarction. Treatment options for cardiac arrhythmia include heart surgery, pacemaker implantation, with diagnostic interventions such as echocardiogram and, if needed, a defibrillator to restart the heart. Pericarditis is the swelling or irritation of the pericardium and can be chronic or acute. Patients experiencing pericarditis are prescribed non-steroid anti-inflammatory medications to reduce swelling. Myocardial rupture is a severe complication of myocardial infarction. It occurs because of weakened damaged muscles within the heart. Myocardial rupture has an extremely high mortality rate, and even if surgery is possible, it is very rarely successful. Ventricular aneurysm is a bulge in the ventricular wall that occurs when oxygen and blood is deprived from the heart, causing cells in the vessel to die and weakness in the vessel walls. These are most common to patients who experience STEMI. Patients who experience ventricular aneurysm manage their symptoms through surgery or by being prescribed anticoagulant medications to reduce the risk of blood clots from forming. Thrombosis occurs when a vein or artery is obstructed by a blood clot, limiting the amount of oxygen-rich blood from entering the heart. Patients who experience thrombosis manage their symptoms by being prescribed anticoagulant medications to reduce the risk of harmful blood clots from occurring. Patients must be continually monitored if using regular antithrombotic medications and titrated depending on coagulation levels in the blood. We hope you stayed engaged for this long, and I hope you've enjoyed our thorough presentation on acute coronary syndrome. Enjoy the two last reference slides.